So what's the rationale for stem cell transplant in lymphomas? Well, many of these diseases, in fact all of lymphomas, have a dose-dependent response to many chemotherapy drugs that are primarily myelosuppressive. Higher dose therapy with radiation, alkylating agents, and others can overcome resistance to lower dose treatment, but this is limited by bone marrow toxicity. And we can use stem cell transplant to restore hematopoiesis after high dose therapy and reconstitute both hematopoiesis and immunity. So as we think about, should we be doing autologous or allogeneic transplants in individual patients and in diagnoses, there's advantages and disadvantages to each approach. With autologous transplants, it's clearly a safer approach. High-dose therapy can be given with a relatively low risk of treatment-related mortality, close to zero now in many categories of patients, but it's limited by the potential of contamination of malignant cells within the graft itself. And really, the biggest limitation is you don't get the immunologic effect of the transplant. You don't get the immune graft-versus-tumor effect. So there's intrinsically a higher risk of malignancy. Nonetheless, in some categories of patients, particularly diffuse large B-cell lymphoma, it can be curative and, in fact, is our treatment of choice in patients with chemosensitive disease. Now, the allogeneic transplant does give us this unique modality of treatment, the immune graft-versus-tumor effect. But we admit that it does so with a higher risk of treatment-related complications related to rejection and even more so graft-versus-host disease. So there's a treatment-related morbidity and mortality is much higher, with mortality rates of 10 to 40% depending on the type of transplant and type of patient. But there is a lower risk of relapse, and so in some patients, this is a unique opportunity for potentially a curative modality of treatment. So the initial idea with transplant is that we could give high-dose chemotherapy and eradicate every last tumor cell, giving a myeloablative treatment, and then we would rescue the patient by a infusion of donor cells, which would then restore hematopoiesis, and that we envision the transplant as a supportive care modality to restore blood counts, but the treatment really was the high-dose chemotherapy and radiation. Well, this was a very toxic approach because we're giving basically as much drugs and radiation as the patient could stand, and then trying to rescue them with the transplant. Now, we've come to appreciate this really doesn't work this way. Even the highest possible doses of chemotherapy and radiation doesn't, in fact, kill every last tumor cell, and it's this immunologic effect of the transplant that really is what's doing the job. And so we, about a decade ago, developed the non-myeloablative treatment strategy that we've done in both myeloid and lymphoid malignancies. And it's illustrated conceptually here, where you have your patient with normal cells and lymphoma. They get a regimen that's designed to be less toxic, non-myeloablative, where we know it's not going to destroy the disease completely, and it'll reduce it a little bit. But when you give the donor cells, the donor T cells and NK cells will react against recipient normal and malignant cells. And when it works, it will eradicate those cells, and you'll get full donor chimerism in the end, and the patient has their malignancy eradicated. And if we see it's not going as well as we like, we can give additional donor lymphocytes to boost this immunologic effect and try to achieve complete remission. And in fact, this has been dramatically effective in certain categories of lymphoma, and I'll review those for you here in a moment. Well, what's the benefit of doing this? Well, of course, when you give less toxic chemotherapy, you're going to get less toxicity and symptomatic manifestations to the patients, and this shows the benefits of this. Just looking at busulfan as a characteristic drug, when we measured the area under the curve, this is the dose delivered of busulfan. And you can see when we give lower doses, we have less mucositis, we have less GI toxicity, we have less hepatic toxicity. But the thing that you probably wouldn't expect, that we also have less graft-versus-host disease. And the reason for that is that graft-versus-host disease is not just an immune effect of the donor T cells against the patient. It's a complex syndrome where you have inflammatory cytokines released by the damaged cells. You have bacteria that get across the GI mucosa when it's damaged by high-dose therapy. And when you give a lower-dose, non-toxic chemotherapy regimen, you then get much less of this global syndrome of graft-versus-host disease and its inflammatory manifestations, and it's thus much safer to the patients. And this is just the diagram that goes with it. And when we compare people getting ablative versus non-myeloablative transplants, sure enough, we see a much lower rate of our major toxicity of allogeneic transplants, acute graft-versus-host disease, and thus the transplant is intrinsically safer. So I'll show you in a moment how that is translated to improved survival in our patients, particularly related to treatment-related mortality, which is much decreased. Well, what are the major indications for transplants in lymphomas? Well, the first one, the common one, both in the U.S. and in Asia, is large cell lymphoma. And their autologous transplants are the standard of care for the treatment of chemosensitive relapse. And one of the controversies really is what patients with large cell lymphoma should you be considering an allogeneic transplant, hopefully getting the benefit of the graft versus tumor effect. Now, in mantle cell lymphoma, as just has been reviewed, autologous transplants are largely used in first remission to consolidate a response, but actually are ineffective when given later in the course of the disease. So once you've relapsed, unlike large cell lymphoma, where autologous transplants are useful in chemosensitive disease, in mantle cell, there's a very high relapse rate with autologous transplants. And we recommend an allogeneic transplant, and I'll show you data here in a minute. And then in low-grade lymphoma, there's a high risk of relapse with autologous transplants. You can get remissions and extended disease-free intervals, but there is a high ultimate relapse rate. And allogeneic transplants are actually can be curative in this disease and are indicated in people with advanced recurrent disease. So one of the few areas in transplant where we actually do have a randomized controlled trial is in patients with recurrent large cell lymphoma. This goes back to the 1990s, the Parma trial showing that in chemosensitive first relapse of large cell lymphoma, that people getting an autologous stem cell transplant had better disease-free survival and overall survival than people getting salvage chemotherapy alone. Now, in the modern area now with Rituxan, this is also true, and we have incorporated Rituxan in our mobilization and transplant strategy, and have at least shown, compared to historical controls, that the inclusion of Rituxan further increases the outcome or improves the outcome of an autologous transplant. So again, we still recommend autologous transplantation for the treatment of chemosensitive relapse of large cell lymphoma. Now, the Rituxan as it's become entrenched in virtually every aspect of treatment, has led to the patients changing, if you will. Now that the people who are recurring after an initial Rituxan-containing regimen actually now have a worse prognosis once they recur, and the results of autologous transplants are actually less favorable because we're now treating people that are Rituxan resistant coming into the transplant. And so this is a study by Gisselbrecht just showing that the results in the Rituxan era now are actually gone down a little bit in terms of the long-term survival with autologous transplants. One of the things that we can use to guide us in the autologous transplants is the response to functional imaging. It's a study done at MD Anderson by our colleague Dr. Lucy, and as has been alluded to by other speakers, people who are PET negative have a better prognosis than PET positive disease, and those people with PET negative disease have an excellent chance to be cured with an autologous transplant, whereas those with PET positive disease have a high recurrence rate. So one of the questions is, should those patients get an allogeneic transplant, and hopefully we could improve their results. Now, unfortunately, this has been a hard thing to prove when we look at registry data. And this, I think, is in large part because we're looking at different patients. Centers that are doing allogeneic transplants are usually doing them in patients where we think that the autologous transplant just won't work because the patient has resistant disease or very poor risk features. And so when we do these kind of comparisons, we're comparing more favorable patients getting the autologous transplants than the allotransplants. But at least in the allotransplant group, we are curing about 30% of people typically with PET-positive disease and a suboptimal response to chemotherapy. So with that in mind, we do recommend that further trials be done, and in fact trying to identify just what patients would benefit from an allogeneic transplant. When we turn to low-grade lymphoma, here we can see a much clearer role for allogeneic transplants. Back in the 1990, Kun Ben Bazine, who's here at this meeting, was working with us, and we began to do high-dose therapy with allogeneic transplants for patients with refractory low-grade lymphomas. And we were very proud of our data at the time because we could cure about half the people. And so this is the survival and disease-free survival on the top lines. But you can see there's a very high early fall-off of patients from treatment-related complications, and indeed about 40% of people ultimately died from transplant-related toxicities. But the relapse rate was very low. It was only about 20%. So we could cure patients with an allogeneic transplant, but with the cost of a lot of morbidity and mortality, clearly not a very attractive option for the patient. And so we thought that this would be an optimal place to evaluate the non-myeloablative transplant strategy. So we took the FCR regimen that was developed by Dr. Keating and his coworkers, and he talked about that in CLL. And we've applied really about the same doses for patients getting an allogeneic transplant. So this is outpatient dose chemotherapy with rituximab, fludarabine, and cyclophosphamide given in a very well-tolerated regimen. And this is sufficiently immunosuppressive that you won't reject an allogeneic transplant. And in fact, we've had a dramatic improvement in the results of our patients with low-grade lymphoma. So this slide shows high-dose chemotherapy with an allogeneic transplant, the red line, high-dose chemotherapy with an autologous transplant, where people didn't die of toxicity, but they died of recurrent lymphoma. And then the green line is people getting the non-myeloablative transplants. And you see we've eliminated the early toxicity, the early deaths related to transplant-related complications, and we have retained the anti-lymphoma effect through the immune graft-versus-lymphoma process. And an update of this data by Dr. Curry, these are his studies that he pioneered, showed that about 80% of patients now are alive and disease-free 8 years later. So again, these patients are selected to be chemosensitive relapse, often with multiple relapses, and that the non-ablative strategy can, in fact, cure this otherwise incurable disease. Now, we think Rituxan is a key part of this, both through its direct effects, but Rituxan largely works by mediating an antibody-dependent cellular cytotoxicity mechanism, and this can actually target, again, the donor cells against the lymphoma to augment their immune graft versus tumor effects, both directly and then indirectly through tumor cells being killed and then being represented by dendritic cells. Now, this is also an effective strategy for other lymphomas, and mantle cell lymphoma, actually, with an update of these slides, has come down a little bit, but for patients with recurrent mantle cell lymphoma, this right now is the only curative strategy for these patients. Again, hopefully some of the new agents you've heard of today are going to fundamentally change the prognosis in those patients. But at least at this time, mantle cell lymphoma, the one curative approach for recurrent disease is an allogeneic transplant. And in some patients with transformed large cell lymphomas, the same low-dose non-ablative regimen has been highly effective. Chronic lymphocytic leukemia, again, the same principles hold, the same regimen has been utilized, and we've seen that patients who get the non-myeloablative transplant, particularly for disease that has not undergone Richter's transformation, is still sensitive to chemotherapy. You can see about half the patients have durable survival, often with donor lymphocyte infusions to consolidate their response, if you will, or to treat minimal residual disease that's left after the initial non-myeloablative chemotherapy. So the same principles apply to CLL patients, and the right results or the outcomes are very dependent on the patient characteristics going into the transplant. Again, one very interesting sort of anecdote that Dr. Curry had noted was that Rituxan can augment this graft versus tumor effect even in the absence of giving additional cells, and that when you treat a patient with recurrent CLL with Rituxan alone, they usually only have a transient response. But here in the post-transplant setting, we had a number of people who got their transplant, still had residual disease, had graft-versus-host disease, so we couldn't give them a donor lymphocyte infusion, and we gave them Rituxan alone, and we actually have several patients who've gone on to get a complete remission, again suggesting that the Rituxan augments the immune graft-versus-tumor effect, presumably through this ADCC mechanism, and these remissions have been durable for several years, again, very unusual, if not unheard of, with Rituxan alone for the retreatment of advanced CLL. Well, we can do transplants for people with matched related and unrelated donors, but now there's new opportunities that you've heard of already at this meeting using mismatched and unrelated cord blood donors to now provide an opportunity for transplants for all patients. And the advance with cord blood transplants is that we can use this for patients who don't have a perfectly matched unrelated donor because there's less graft-versus-host disease with a cord blood transplant, and that we can get sufficient stem cells from a large cord blood unit to even transplant adults. There are now a series of cord blood banks around the world, and we can again find donors for most patients. And our main problem has been the low cell dose that we get from an individual cord blood, and what we're trying to do from that perspective is expand those cells in vitro before giving them post-transplant. But you can see the outcome with the cord blood transplant that we can do almost as well as we can with an unrelated donor transplant. And in fact, in centers that have a large interest in cord blood transplantation, the results now are really the same with cord blood transplants as with matched unrelated donor transplants. And one of the major advantages of this is now we can address people from minority racial groups that are not well represented in the national and international registries. And so in our program at MD Anderson, if we just relied on related donors and the unrelated donor registry, only 25% of minority groups could get transplants, whereas now 60% of those patients can get transplants when we use cord blood. Haploidentical transplant is the other option, using a new approach with post-transplant cyclophosphamide. And with that approach, and we've heard about that already in this meeting, we can reduce the risk of graft-versus-host disease and achieve results very similar to what we can with matched sibling donors. So this just shows you the results with haploidentical transplants in our hands, treatment-related mortality of only 15%. So again, very similar to what we can do with matched siblings or matched unrelated donor transplants. So now nearly every patient can get a transplant, and many patients with advanced lymphoid malignancies have a curative option in treatment where there is otherwise no other curative option currently available. What can we do in the future to build upon this? One is to try to give a specific cellular therapy targeting the tumor, and using chimeric antigen receptors, you can actually create a T cell that will specifically react with CD19, present on all B-cell malignancies. So one basically takes the antibody binding domain of a monoclonal antibody, grafts it to the T cell receptor. Now you've redirected the T cell to instead of reacting against the virus or whatever the native T cell receptor would target, this new chimeric T cell receptor will target CD19, present on every B cell and B cell malignancy, and you can then have basically a T cell that acts like Rituxan, if you will, to target the B cell specifically. And it's some very exciting data with the preliminary use of these cells to induce remission in patients with far advanced CLL and lymphoid malignancies. So we hope that we can use cellular therapy to further augment the immune graft versus tumor response. And lastly, NK cells are another source of cells that can be added to an allogeneic transplant to boost the reactivity against the malignant cells. So we're running out of time, and so I won't go into this in too much more detail. And then the final thing that we can do to try to make transplants safer for patients is to see if we can eliminate graft-versus-host disease. And so one approach to this is to actually put a suicide gene into the T cells that we're giving to mediate the anti-tumor effects. A modified caspase-9 has been used for this purpose. This is a protein that's inactive in its natural state, but it can be activated by a dimerizing agent that will dimerize the protein and then turn on its natural caspase activity, basically killing the cell that is causing graft-versus-host disease, and then eliminating that process. So basically, we take the cells, we transduce them with the modified caspase-9, we give them to the patient, let them mediate the anti-tumor effect. If they get graft-versus-host disease, we can turn it off by use of this suicide gene. So in the end, we hope we can give a safe allogeneic transplant, capture the benefits of graft versus lymphoma effects, cure patients with advanced disease, and do so with much less toxicity than we see today. So in conclusion, high-dose therapy with autologous stem cell transplant is the treatment of choice still for a patient with most aggressive lymphomas. Allogeneic transplants offer a potent graft versus malignancy effect that's potentially curative for advanced lymphoid malignancies. Cellular immunotherapy using these anti-CD19 reactive T cells or NK cells is a promising treatment for lymphoid malignancies to augment the anti-tumor effects, and novel, more effective strategies to prevent graft-versus-host disease while maintaining these graft-versus-leukemia effects will further extend the use of allogeneic transplants for the treatment of lymphoid malignancies as well as other cancers. Thank you.